Yeah, hello and welcome to the Tulip Airway channel. This is video number 28. This is about semi-conscious airway management. So we're talking about induction, we're talking about recovery, we're talking about people coming into A&E in a semi-conscious state due to drugs overdoses, COPD complications, things like that. Now, semi-conscious airway management to me is the most difficult by far. I personally don't see what's so hard about unconscious airway management because the patient's unconscious. You've got every option available. You can use an ET tube, you can use an LMA, you can use an iGel, you can use a Guedel. But in the semi-conscious condition, you can't tolerate an ET tube, a laryngeal mask, or an iGel, so you've only got a Guedel and mask. Now, the reason that's a problem is basically working in A&E, basically you can see these patients with drugs overdoses, recreational drugs overdoses, COPD complications, post-RTC, strokes, head injuries, anything like this. But it seems as though deterioration is almost part of the plan because you haven't got any options. Now, I'm not suggesting for a moment that that's what we want to happen, but that's almost what you don't have a choice but to happen. Because what happens is when the patient first comes in, we use a Guedel and mask because they're semi-conscious. You can't use anything else. You can't use iGel. You can't use an LMA. So we manage as best we can. Patient struggles. They're hypoxic. They may be fighting. They may not. But as the patient is being managed and we're trying to get some kind of control, the patient usually deteriorates. That means the physiological parameters worsen, the saturations are off, the blood pressure may be down. Of course, there's a complication of whatever the initial cause is. If it's a drugs overdose, it might be hyperventilation. If it's, a road traffic accident, it could be hypovolemia. But still, there's no other choice other than a Guedel mask when the patient is still semi-conscious, so the patient still tends to deteriorate. But what then happens is the semi-conscious becomes fully unconscious. Right, and now you can move up to an iGel, an LMA, an ET tube, and only once you've instigated these these hands-free directly connected devices, does the anaesthetist, does the doctor have full control. Only then do you get access to the 100% O2, because with the Guedel mask, of course, it's widely agreed, maximum is about 60% because you're rebreathing into the mask. So what happens is here's basically the stages and planes of anesthesia. Okay, so you've got 1, 2, and then of course 3 and 4. Now 3 is considered anesthesia in itself. This is 1 and 2 is really kind of induction type of thing and recovery on the way back up again. So for a Guedel, you can use it in all of the stages and planes, right? So that's because you can use it in semi-conscious, therefore you can use it in fully unconscious. The only problem is it's not hands-free or directly connectable. You don't tend to get very good ventilation with it, and if you do, you're really using high pressures, so you're kind of really inflating the stomach as well. With a laryngeal mask and an iGel, you can only use it in stage 3 of anesthesia, which is plane 1, 2, 3, and 4. You can't use it in 1 and 2 because it's just not tolerated. So you can't use LMAs and iGels in the semi-conscious. A tulip, on the other hand, can be tolerated by the semi-conscious and therefore, just like a Guedel, it can be used in all stages and all planes. So, in addition to the fact that it can be used in all stages and planes like a Guedel, the additional benefit is it is hands-free, it is directly connectable, and you can still use it in semi-conscious states. Now, when I say semi-conscious states, basically if a patient is losing their airway reflexes, they can tolerate a tulip. And basically, if they are emerging, it's usually GCS 13, 14. And we're going to have a look at a couple of videos now, 2 sets. One I know is an old lady you've seen before, but there's another gentleman involved. All the videos have been taken with patient consent, otherwise I wouldn't be showing them. But the reason the tulip can be tolerated in this semi-conscious condition is because it's oropharyngeal. So it sits in the glossopharyngeal nerve distribution. It makes you swallow, it doesn't make you gag. So it's extremely low stimulation. And in addition to having all the benefits of the Guedel semi-conscious ability, the tulip is hands-free, it's directly connectable, And basically it sits within the glossopharyngeal nerve distribution, which is the green area. Now, if you look at the tulip on the top left, you'll see it's sort of vaguely triangular in shape. And you notice the basic glossopharyngeal nerve distribution is the same. You'll see on the bottom left that the ET tube comes right down into the recurrent laryngeal. Now, of course, you can't tolerate that awake. The LMA and iGel neither. And the Computube is, also intolerable when semi-conscious. So basically, in the ideal airway, you would be able to use it in all stages and planes, right? So in fully conscious, unconscious, well, sorry, forgive me, you can't use it in fully conscious, semi-conscious, right? But ideally you'd be able to use it any time. Now, here's the good news. When I said fully conscious, you can. Because basically Tulip is being used for sedation. What you do is you spray the inside of the throat with lidocaine. You give it 3 to 5 minutes. Be careful of the toxic dose and how many sprays you use. Basically, that numbs the glossopharyngeal nerve distribution, and then the Tulip can be tolerated awake for sedation. Now, the other thing they do for sedation is they insert it in an uninflated condition and only inflate it if they need to. So, this is a lady whose video you've probably seen before, but I think it's important. Now, what's important is this lady self-extubates. She doesn't gag, she doesn't vomit. She basically, at the very beginning of the video, in second 1, she swallows. At second 10, she coughs. And at second 14, she clears her own throat. Then she proceeds to answer questions. So I don't think there's any discussion about whether she's awake or whether the reflexes have returned, because there's 3 sets of those being shown. And I estimate her Glasgow coma score to be in around 14 at emergence on this self-extubation.
Open your eyes, please. Yeah.
You pull that out if you want to, Anne. That's good.
Good. Excellent. Oh.
How do you feel? You wide awake?
Yes.
How's your throat feel?
Okay.
Thank you very much.
So I think that basically is a good demonstration of almost fully conscious emergence. Now we're going to have another one with a gentleman. Now, this gentleman is unconscious for a lot longer, semi-conscious for a lot longer. He has the tulip in his mouth for a lot longer, and I think it's fair to say that he tolerates it really well. There's no gagging, there's no vomiting.
For me, that's it. Open them nice and wide.
Open your eyes and you can pull that tube out yourself.
Open your eyes, Timur. Have a look at all of us. Operation's finished. You're just waking up.
Do you want to pull that tube out, Timur?
That's it. Reach up for the tube in your mouth.
Open your eyes for me. That's it. That's it. Would you like to pull that tube out?
Well done.
You do it.
You do it, Timur. That's it.
Can you? Good boy. Thank you very much indeed.
Well done.
Patient is now.
On, you know.
Patient is now fully awake. Open your eyes for me. Do you feel okay? Patient is eyes open, self-extubated. He's taking some oxygen now. The parameters are all satisfactory.
Now, again, I've got to tell you that basically these videos were taken with the patient consent, but I think you've got 2 examples of how well a tulip is tolerated in a semi-conscious condition now. So the question is why do we have quite so many airways? I mean, if a Guedel mask was, hands-free, directly connectable, would you need a laryngeal mask or an iGel? And the other way around, if a laryngeal mask or an iGel could be tolerated semi-conscious states, would you need a Guedel mask? Well, that's what a tulip is. It is hands-free, it's directly connectable like a laryngeal mask and an iGel, but it's tolerable in the lighter planes of consciousness, and you've seen that. So that's what a tulip is. It's a combination of all those different functions. That's what a tulip looks like. The headband versions are really for the anaesthetists in theatres, stability, additional, ease of use. The ones on the top left are more for kind of Guedel type replacement, slightly cheaper. But basically, the tulip versus a Guedel mask is the studies we did. We can't do any more studies because apparently everything I do is prejudiced. But that's probably true because I know what a tulip can do. But basically, Tulip has been shown and published and presented as having been 100% successful first time. Now that's in a number of trials, not only our own, but independent studies. The tidal volumes are up by 77%, delivering, 200%, 250% more oxygen. And it also reduces pressure because it's got such a big tube. That then also, of course, reduces regurgitation risk. So, yeah. For semi-conscious states, that patient who comes into A&E is deteriorating rapidly. If you use a Tulip, you get an instant impact. You get full airway control, full IPPV, no leak. You improve oxygenation, ventilation, stability, all physiological parameters. Now, this has happened on a number of occasions, and Tulip will work when other things don't, and that includes Difficult Airway Society Plan ABC. That's more discussed in more greater detail in video 2, because that's proper hardened evidence with actual statements from consultants in 3 different countries. That's what a Tulip looks like. I'll see you on the next video.